Well, what's very exciting in the U.S. is the number of integrated models that are currently coming online that combine both global or accountable payment with coordinated delivery models on the ground. And I'd like to tell you about a few of those different models as examples. Unfortunately, a lot of the results right now are still, the evaluations of these models are still ongoing and results are forthcoming. So we don't know how and whether these models will work, but I think it's very exciting on a number of levels. We have examples of managed care in the US, of blending Medicare, healthcare coverage for older adults with long-term care coverage under Medicaid. And so those are blended in a managed care product where different providers receive a capitated rate to manage both their health and long-term care services. An example of this would be the Medicare Advantage special needs plans. Other examples of coordinated products for dually eligible individuals is one of the innovations under the Affordable Care Act, or Obamacare, or the integrated care demonstrations that are happening in 26 US states. And these programs blend both payment and delivery level innovations by combining services, Medicare services, coverage for healthcare with Medicaid long-term care services. We've seen a real growth as well under the Affordable Care Act of accountable care organizations. To date, these ACOs have largely examined the Medicare side of the continuum. It'll be really exciting as more and more long-term care providers are brought into these ACOs. And finally, there's a great example of an integrated model from pay for performance that occurred in the state of Minnesota. I was involved with Greg Arling and Valerie Cook in the evaluation of the PIP program. And I would say more about the PIP, only Greg and Val are at the meeting, and we'll be doing one of the plenaries later in the conference. So you can learn all about PIP, but I'll say that PIP does an excellent job of combining payment innovation with delivery innovation. We actually saw big effects in terms of improvements in quality. So I think you should very much look forward to Greg and Val's presentation. What are some of the challenges moving forward with these integrated models? I think a real challenge in the US, and I'll be interested to hear if this is the experience in Canada as well, is that many of the healthcare providers, as they're developing systems and networks, have very little experience in working with long-term care providers or in working with the long-term care population. What magnifies this issue and complicates it further is that the U.S. Nursing home population has changed dramatically over the last 20 to 30 years. Relative to the 1970s and 80s, there's much greater dependency in activities of daily living and much greater medical complexity in the nursing home population. I realize short stay rehab patients isn't a part of your nursing home sector, but here in the US, more and more, we're seeing a segmentation of short stay and long stay providers. And those specializing in short stay, often higher revenue patients, are separate from those specializing in long stay, compensatory long-term care services. If facilities are more and more caring only for long stay residents, there's a question of whether they'll have sufficient revenue to provide quality at a high level. We've seen increases in the rates of dementia. We've also seen increases in rates of mental illness. And Paula suggested to me that this was a real area of concern in Ontario. And so I'd like to say a few more words about my research on this issue and sort of the changing demography of the U.S. Nursing home population around mental illness. I think historically there were relatively few individuals with mental illnesses in nursing homes. However, as we began to see closure of state psychiatric hospitals in the U.S., these individuals left that institutional setting and often found themselves in nursing homes. So the classic policy problem, you push down on the balloon in one place, the problem comes up in some other area. And these are some data our team published in 2009 in the journal Psychiatric Services. And this just tracks dementia, mental illness, and individuals being admitted with both over the period 1999 through 2005. And these are national data from the minimum data set. You can see at the start of the period in '99, the dementia-only population was about 18%, the mental illness population was about 14%, and both was about 6%. That's a triangle. That 6% is relatively constant. However, we see this flip-flop of the dementia-only and the mental illness-only. And by the end of the period, mental illness-only admissions are about 18%. When we add that to the 6% that also have dementia, 1 in 4 nursing home admissions by 2005 had a mental illness. I think this was much higher than most policy types and provider types realized. And also when compared with dementia, I think this was quite surprising to a number of individuals. What about the age profile of the nursing home population? Well, these are some data we published in 2009 in Health Affairs. You can see when we define mental illness very narrowly in the histogram on the left there, and this is just using schizophrenia and bipolar disorder, you can see that half of individuals are under the age of 65. When we use a broader definition of mental illness that encompasses depression and anxiety, about 20% of admissions are below 65. If we look at individuals without mental illness, about 10% of individuals are under age 65. So if we're going to sort of characterize individuals with serious mental illnesses that are being admitted to nursing homes, they're largely under the age of 65, and they're growing in prevalence over time. So how might we think about addressing quality of care for this population? The study of individuals with mental illness in nursing homes is still growing, but the results to date suggest quality of care is a real problem for this population. And part of that I would tie to payment, and part of that is to delivery once again. On the payment level, most U.S. state Medicaid programs don't pay a rate commensurate with the higher cost of caring for individuals with serious mental illnesses. And so there's a disincentive to admit them, and conditional on admitting them, there's real challenges in terms of providing high quality care. On the delivery level, we've seen a lot of specialization in the care of dementia. We have special care units and a number of other settings around the U.S. that specialize in dementia care. We have relatively few providers that specialize in the treatment of mental illness. There are some state-run nursing homes that focus solely on treatment of mental illness. But by and large, individuals with serious mental illnesses are embedded in the mainstream nursing home population. Whether that's a good thing is still quite unclear. And so I think there's a ton of research left to be done on how we pay for care for individuals with serious mental illnesses and how we deliver services on the ground. And ultimately, much like the theme of this overall talk, I think we need to tie those two concepts together in order to truly move the needle. So let me say a few words in conclusion, and I wanted to go back to the patient vignette that I put forward earlier in the talk, Miss B. And I wanted us to imagine not the case I put forward before where she had fragmented payment and fragmented delivery of services, but rather an integrated payment and delivery model of care, where Miss B has a comprehensive set of benefits for primary care, acute care, pharmaceuticals, and long-term care, a coordinated, experienced provider team with a strong network of providers that are used to working with individuals with long-term care needs, a comprehensive individualized care plan, and healthcare decisions like the decision to hospitalize that are made based on her needs and preferences and not the financial incentives present in the system. I hope that's the model we're moving towards in the U.S. I think you can agree and hope that that's the model you're moving towards in Ontario. I look forward to your questions and comments, and I appreciate the opportunity to speak today once again, and thank you for allowing me to do this remotely. Thank you.